We just want to take a moment to welcome everybody to our Grand Rounds presentation. I do want to mention for everybody who is interested in CME credit that we do have the code listed here for you for today's session. It is 1008-7602. If you could go to the next slide, Dr. Kirkpatrick. For those who haven't registered, you will still need to register first by sending your email address to the phone number listed, and I'll post these instructions also in the chat box in a moment after the introduction. But you'll need to first text your email address if you haven't done that yet. If you already have, then you simply just need to put in the code and then attend for today's session. So I'll put that information in the chat box here in just a moment, but we can go to the next slide. So as we also get started, if you could just make sure that your microphone is on mute. Dr. Kirkpatrick has mentioned that she will take messages in the chat box throughout. So I'll be moderating that. If you have questions, just put them in there for us. And then of course, if you could also help us out, I'll put the link at the end of the session for our evaluation. So you could help us out with that if possible, please. Next slide. So this is the South Texas Regional Family Medicine Grand Rounds, and we are partnered with the South Central AAHIVP, and our department's mission statement is there for you. Next slide. So I've already mentioned CME, but if you are interested in viewing your transcript, you just need to go to the CME website listed there, and then you can view your transcript. You will need that transcript as we are also offering AAHIVP credit. So that information is on the next slide. We do offer credit for this presentation through the AAHIVP as well. It is 1 credit, so you'll just need to get that transcript from CME and submit to the AAHIVP. But if you have questions about any of that, please feel free to contact me, the CME office, or the AAHIVP. Next slide. We also do want to mention that it is our goal at these Grand Round sessions to address the nationally established physician core competencies that you see listed there. Next slide. We also want to make sure that we do mention Dr. Kirkpatrick has no financial relationships with ineligible companies to disclose. So she is a PharmD coming to us from University Health. She is going to talk to us about the Be Prepared, the ins and outs of providing pre-exposure prophylaxis for the prevention of human immunodeficiency virus. So I will let her go ahead and get started.
All right, can everybody hear me okay?
Sounds good.
Awesome. Well, thank you so much for the introduction. Like she said, my name's Emily Kirkpatrick. I am one of the clinical pharmacy specialists in infectious diseases, and I primarily work with our HIV population, both inpatient and outpatient at University Health. And so we're going to talk a little bit about PrEP today. So first, I want to start with what my objectives for you all are after listening to this presentation. So we're going to start with talking about the epidemiology of our newly diagnosed HIV infections in the United States, move into talking about what medications we actually use for PrEP, how to actually identify high-risk patients in your own practice, and then finally at the end, we're going to walk you guys through talking about how do you actually do an initial PrEP visit and what do you need to do for follow-up for your patients that might be eligible. So like I said, let's start with the epidemiology. So the CDC's most recently published HIV surveillance report estimates that as many as 13% of the 1.2 million adolescents and adults currently living with HIV in this country are actually unaware of their HIV positive status. And this large undiagnosed population is at an increased risk for unknowingly transmitting the infection to others. In 2019, just under 37,000 people were newly diagnosed with HIV in the US, and while it is promising that the overall number of new HIV diagnoses have been continuously increasing over the last, or decreasing over the last couple of years, you do need to keep in mind that there are certain groups where this is not true, and the rates of new diagnoses continue to increase among certain parts of our population, which we're about to cover. So looking at this CDC infographic, you can see that of those who are newly diagnosed, our gay, bisexual, and other men who have sex with men community, or MSM, account for the overwhelming majority of cases at 69% of new infections. And when we break it down by subpopulation, among those newly diagnosed men who have sex with men, our African American and Latino MSM population are disproportionately affected compared to their white counterparts. And similarly, if you look at the patterns among newly diagnosed heterosexual populations, you're going to see those same two groups being more affected. In addition, when we look at new diagnoses by age group, you can see that the younger adults are also going to be more disproportionately affected, with 1/3 of new diagnoses occurring among those between the age of 25 and 34. And then you can also see kind of sandwiched on either side, our next two highest groups are going to be those 13 to 24 and those 35 to 44. So because of this, in 2014, the Joint United Nations Program on HIV/AIDS, or UNAIDS, set their ambitious 90-90-90 goals. And so what this means is basically their goal was that worldwide, 90% of all people living with HIV would have their infection diagnosed. Of those, 90% of them would actually be put on antiretroviral therapy. And then of those people, 90% of them would actually be virally suppressed. It is predicted that if we were able to reach those 90-90-90 goals globally by the year 2020, that these actions would end up ending the HIV epidemic by the year 2030. And so the question you may be asking yourself is, so we're in 2021 now, so how did we actually do? By the beginning of 2020, the US came close to meeting those 90-90-90 goals by reaching the percentages that are listed on the slide. Unfortunately, though, even with this improvement in HIV treatment, it's unlikely that this is actually going to be enough to end the epidemic. So because of that, UNAIDS has set new targets of 95-95-95, which would result in 86% of those diagnosed being virally suppressed. And interestingly, a recent modeling study predicted that we could achieve an impressive 67% reduction in global HIV incidence by the year 2030 if we were able to meet those new 95-95-95 goals, but also combine that with 40% of our MSM population utilizing pre-exposure prophylaxis. And so living in the South, I think it's important for all of us to realize that we do live in the epicenter of the US epidemic. And partially to try to combat some of this, a couple of years ago, they started a new initiative to end the HIV epidemic in the US, where they have allocated $291 million in funding in order to distribute it to the counties in the United States that have the highest burden of new HIV diagnoses. And as you can see here, 48% of these highest risk counties happen to be located in the southern United States. Unfortunately for us, our very own Bexar County is at the highest end of the spectrum. In the year 2018, we had 325 new diagnoses. And I guess the good news here is that in 2016, we actually had more than that at 364, or roughly one new diagnosis per day in the year 2016. But I think regardless, we can all agree, we definitely have a ways to go. And so this all brings me to a discussion of our preventative strategies. So what can we do as clinicians to help reduce the incidence of HIV in our community and beyond? So when we're thinking about types of preventative strategies, we can categorize them into either pharmacological or non-pharmacological. And while the focus of our discussion today is really going to be about PrEP, a pharmacologic strategy, it is important to remember that these non-pharmacologic strategies like safe sex and harm reduction counseling are things that we really should be integrating into the routine clinical practice and always should be utilized in addition to the pharmacologic strategies. And so before I get into talking about PrEP, I did want to briefly review for you guys and explain what treatment as prevention and post-exposure prophylaxis mean first. So treatment as prevention is just what it sounds like. The goal is that we want to treat everyone who has been diagnosed with HIV in order to reduce their viral load to undetectable and therefore reduce further transmission of the virus to others. And so there's a growing body of literature that really supports the effectiveness of this strategy. You can see that in 3 of the 4 studies summarized here, where they evaluated serodiscordant couples, which basically means one partner is HIV positive and the other partner is HIV negative, there were 0 linked transmissions of the HIV virus when the HIV positive virus partner actually had an undetectable viral load. And of note, in the one study that they did observe a single link transmission, the event was determined to have occurred before the HIV positive partner was actually able to achieve virologic suppression. And so the takeaway from this is that our published literature clearly supports the idea that patients who maintain virologic suppression of their virus by being adherent to their antiretroviral therapy cannot sexually transmit the virus to others. And so this evidence is really what led to the overwhelming endorsement of the U equals U campaign, which this means undetectable equals untransmittable. And so as clinicians, it's really our hope that this message is going to encourage more people with HIV to actually seek treatment and works a little bit towards eliminating some of the stigma that surrounds this population. It's really important to get people on therapy because it allows them to live a long, healthy life, and they don't have to worry as much about having to think about passing that virus on to somebody else. So that's treatment as prevention. The next one I want to cover briefly is post-exposure prophylaxis, or PEP. So post-exposure prophylaxis refers to the administration of a short 28-day course of antiretrovirals that is initiated as soon as possible, but within 72 hours after a potential exposure, in order to attempt to prevent an infection from taking hold in the patient. So you can see there's kind of two different categories. Your exposures can either be occupational or non-occupational. And one thing to keep in mind is that potentially the occupational exposures are going to be easier to manage because typically they're going to be more frequently able to actually test that source patient for HIV, initiate the antiretroviral therapy much quicker after there is an exposure, and these events are often associated with less physical or emotional trauma. So in order to decide if somebody actually should receive PEP, you have to assess the type of exposure and associated risk for HIV transmission. This table on the slide summarizes the transmission risk per incident after various types of exposure to an HIV positive source with a non-suppressed viral load. You can see that the transmission risk associated with blood transfusion and vertical transfusion far exceed the other types of exposures on this list. And then when we're thinking about risk regarding sexual transmission, it's comparatively low overall, but it is higher if you're talking about receptive anal intercourse. And then most patients that are presenting for PEP evaluation typically are going to be either needle stick injuries or sexual exposures. So here I just wanted to briefly summarize for you guys what the recommendations are for treatment. And so our antiretroviral options for PEP favor a 3-drug approach. So you're going to combine 2 nucleoside reverse transcriptase inhibitors and either an integrase inhibitor or a protease inhibitor, again, for a total of 28 days. So I have a lot of the recommended alternative regimens on here as well, but the #1 preferred regimen is the one that's highlighted in orange here. And when we're thinking about PEP, one thing to keep in mind is that many of those non-occupational PEP patients may actually be good candidates for other prevention strategies such as PrEP, particularly if this is somebody that has received multiple courses of PEP, and especially if they tell you they have ongoing risk for HIV exposure. So that final PEP appointment is a good time to think about transitioning the patient over to post-exposure prophylaxis, especially again, if there's someone who has ongoing risk factors. So at this point, you guys may be asking yourself, what exactly is PrEP? And pre-exposure prophylaxis refers to the proactive use of antiretrovirals in an HIV-negative individual to reduce the risk of acquisition of HIV in patients that are high risk for obtaining the infection. And the U.S. Public Health Service does recommend that all female or male patients who are sexually active or are known to be injecting illicit substances be assessed by a clinician for their risk of acquiring HIV. And these patients should also be offered PrEP as one preventative strategy, basically if their sexual or drug use behaviors place them at a substantial risk for acquisition. So one thing that's really important to know is that we don't use all antiretroviral medications for this indication, and so which ones are we focused on? The medications that are FDA approved for use as PrEP fall into the class of antiretrovirals called nucleoside reverse transcriptase inhibitors, or NRTIs. And these medications work at step 3 of the HIV life cycle, which I have depicted here for you, and they block the enzyme reverse transcriptase, which the virus needs in order to make copies of itself. And when we're thinking about our FDA approved products for this indication, the nice thing is there's really only 2 that we have to think about, and they're different salts of the NRTI TENOFOVIR combined with the NRTI M-tricytidine. And one thing you guys may be thinking is, okay, out of all of the different options that are out there for HIV, how did we come to using tenofovir for specifically PrEP? And there's a lot of factors that went into this. It has been used for a really long time as part of our ART regimens for the treatment of HIV positive individuals, and it's been seen to be really well tolerated with an excellent safety profile. In addition, it has fewer drug interactions compared to many of our other antiretroviral options, and it does not interact specifically with hormonal contraceptives or opiates, which makes it a really good option for this population. Tenofovir also has a really long intracellular half-life, which A, allows us to do once daily dosing, but B, also may potentially be more forgiving if the occasional dose is missed by the patient. And then finally, tenofovir also already has some literature supporting its use for the prevention of vertical transmission in humans, and then a little bit of animal data supporting its use for preventing the transmission of the simian immunodeficiency virus after viral challenge. So I want to spend the next couple of minutes talking about the differences between our two products. So Descovy is going to be the newer of the two agents, and it contains tenofovir alafenamide or TAF. And then Truvada is the older of the two agents, and it contains tenofovir disoproxil fumarate or TDF. And again, both of these are combined with emtricitabine, so you're getting two drugs. So kicking it off, talking about Truvada. It was FDA approved in 2012 for the indication for PrEP. And the nice thing about Truvada is it has robust data that demonstrates efficacy in all of our key at-risk populations. So our MSM, transgender women, heterosexuals, and persons who inject drugs. And this medication is a single tablet that's given daily with 300 milligrams of TDF and then 200 milligrams of emtricitabine. For some clinical pearls to know about this medication, you do want to avoid it in anybody with underlying osteoporosis or if they have pre-existing renal dysfunction. For this product specifically, they do recommend that you don't prescribe it for anyone with a creatinine clearance less than 60. And in terms of counseling points, generally these medications are very well tolerated, but especially initially, some patients may experience what is often referred to as startup side effects. So this may be a little bit of nausea, vomiting, diarrhea, dizziness, headache. And patients really need to be counseled that while they may experience these side effects initially, they typically go away within the first few weeks of therapy all the way up to 1 month, depending on how severe they are. And if they're able to power through that, they should have no problems down the line. The next medication to review is Descovy. So this one was FDA approved in 2019. And in contrast to Truvada, evidence supporting the effectiveness of Descovy in PrEP actually only comes from a single randomized controlled trial that included primarily MSM with a few transgender women, but really excluded those at risk from receptive vaginal sex or from injecting illicit drugs. And so when we're comparing Descovy to Truvada, the main difference to note again is that different tenofovir salt form. So thinking about TDF and TAF, they're actually both prodrugs of tenofovir, but while TDF gets activated in our bloodstream, TAF doesn't get activated until it actually enters the cell. And so this leads to higher intracellular drug levels at the site of action, despite the fact that we have lower plasma levels. And it is this difference that we use to explain the difference in the doses. So in this product, you can see TAF is only 25 milligrams, whereas in Truvada, again, that TDF was 300 milligrams. In addition to this, the lower plasma concentrations are also thought to explain the decreased effect of TAF on the kidneys and bones compared to TDF. So that being said, you do have to keep in mind though that TAF may be associated with increases in LDL cholesterol and weight gain compared to TDF. So you get a little benefit on one side and then maybe some cons on the other. Just as a reminder, again, with this one, you still want to talk to the patient about the same startup side effects as Truvada. But one interesting theory about Descovy is that it might be potentially more forgiving with missed doses. Basically, the thought here is that because Descovy achieves higher or more sustained drug levels within our peripheral mononuclear cells that are targeted by the HIV virus, it may be more forgiving than Truvada with regards to the missed doses. Now, that being said, clinically, we're not totally sure exactly how that's going to actually play out. And it should be noted that Descovy actually does achieve lower concentrations compared to Truvada within our genital and rectal mucosa. So now that we've talked a little bit about our drugs, let's move into talking about what clinical evidence exists to support the use of these antiretrovirals for PrEP. So the first place I'm going to start is talking about some of the trials that have looked at our MSM population. The first of which is going to be the IPREX study, which was published in 2010. This randomized controlled trial demonstrated the safety and efficacy of daily Truvada in MSM and transgender women. For their safety outcomes, what they saw here is that there was low overall rates of nausea and serum creatinine elevation. And what I thought was really interesting about this one is that while they saw a 44% relative risk reduction overall compared to placebo, among patients that actually had detectable levels of Truvada in their system, there was an impressive relative risk reduction of 92%. And so these findings really highlight the importance of adherence to the effectiveness of daily Truvada when we're trying to utilize it for HIV prevention. After that, the next question that was asked is, basically when we're thinking about the two drugs that are in Truvada, we have emtricitabine and tenofovir. And tenofovir is really potentially the more toxic of the two. So they did this US MSM safety trial to evaluate the safety of TDF compared to placebo without emtricitabine as a confounder. While they did see in the multivariate analysis in this one that there was an association between back pain and TDF, there were no fractures observed in this population. And of all the adverse events that were experienced by patients, 97% of them were categorized as mild or moderate in nature. And so these results were used to further support the safety of tenofovir for the utilization of PrEP. In 2014, they also did an open label extension of the IPREX study that we just talked about. And this is where patients were offered to continue PrEP free of charge, and then 76% of the original trial participants accepted this offer. To orient you guys to the graph that is over on the right-hand side of the slide, the x-axis is depicting our tenofovir concentrations. And basically they have this divided up by the number of tablets of Truvada the patient was actually taking per week, while the y-axis is depicting their HIV incidence. The incidence per 100 person years in patients that were off of PrEP was 2.6, and this is represented by that solid red line. And then when we think about patients that were actually taking PrEP, the overall incidence was reduced to 1.8. However, if you look at the lines on here, you can see that the incidence among patients that were actually taking at least 4 doses per week was essentially 0 and increased as daily adherence to PrEP decreased. And so again, this is a really good highlight that adherence is key when we're thinking about PrEP populations. The PROUD study was published in 2016 after this, and it was an open label randomized controlled trial that included MSM who reported having anal intercourse without a condom in the 90 days prior to inclusion. Participants were randomized to either immediate or delayed PrEP initiation, and interestingly for this trial, it was actually stopped early after an interim analysis showed an 86% reduction in HIV incidence in the immediate start group. When we break it down a little bit further, of the 3 cases observed in the immediate group, 1 was determined to be a pre-existing HIV infection, and 2 actually occurred in patients who were non-adherent. And then when they looked at other sexually transmitted infections, they saw no observed increase in that immediate group compared to the delayed group. Authors also estimated that for every 13 men treated for 1 year, they could prevent 1 HIV infection. And then finally, to round out this section, we will talk a little bit about the landmark DISCOVER trial. So like I mentioned earlier, this is the only trial that evaluates Descovy's efficacy in PrEP, and these results led to its FDA approval for this use in 2019. You can see here that the population consisted primarily of MSM with comparatively fewer transgender women included. And then notably, again, this trial excluded cisgender women. And because of this, Descovy is not indicated for PrEP in people at risk for HIV acquisition from vaginal intercourse or from IV drug use. The results of this trial demonstrated non-inferiority of Descovy compared to Truvada for this indication. And they also reported, interestingly, that Descovy had less of an impact on kidney function and bone mineral density at 48 weeks. So now that we've talked about MSM, what about some data looking at our heterosexual men and women? So in 2012, they published the Partners PrEP study, which was a randomized controlled trial evaluating Truvada or TDF alone versus placebo as PrEP in serodiscordant couples in Uganda and Kenya, where the HIV positive partner was not receiving antiretroviral therapy. Of note, medication adherence was high and the rates of serious adverse events were low, looking at the baseline characteristics of this population. And this is another trial where, again, it was stopped early after the interim analysis demonstrated a statistically significant risk reduction of 67% in the TDF group and 75% in the Truvada group. In that same year, the TDF2 trial was published, which is again another randomized controlled trial evaluating Truvada in heterosexual men and women. But in this case, what they did is they combined it with comprehensive prevention services, which included testing and treatment, risk reduction counseling, and provision of condoms. Again, medication adherence by pill count was relatively high in the study at 84%. Unsurprisingly, the rates of nausea, vomiting, and dizziness were higher in the Truvada group than the placebo group. But overall, daily Truvada use was associated with a 62% risk reduction. In addition to the data that I just presented, we also have a little bit that looks at PrEP for persons who inject drugs. So the BANGKOK, Thailand TENOFOVIR study was a randomized controlled trial that was published in 2013 that evaluated the use of daily TDF alone as PrEP in persons who inject drugs. Participants were basically given the choice to either do directly observed therapy or receive a 28-day prescription. And the majority of patients decided that they wanted to do the directly observed therapy. Among those that had high adherence, a risk reduction of approximately 74% was observed. But again, the key here is that high adherence. And so I know we went through a lot of different studies, and I wanted to give you guys a summary slide about what we talked about. But really the key takeaway from everything in here is that all trials discussed the risk of HIV diagnosis, and that was able to be reduced by using PrEP. You can also see that across the board where evaluated, adherence was what really made the difference. If you have a patient that takes PrEP and has high adherence, you can reduce that HIV risk by up to 92%. So like I said, I know we've gone through a lot of information so far, and I want to make sure you guys are actually still awake. So we're going to do a couple of knowledge check questions. So feel free to just put your answer in the chat box, but which of the following antiretroviral medications is not a component of an approved PrEP regimen? Is it A, tenofovir disoproxil fumarate or TDF, B, abacavir, C, tenofovir alafenamide, or D, emtricitabine?
We have, I don't know if you're able to see the chat box. We have some responses for B.
Yes, that is absolutely correct. So abacavir is actually an NRTI, but it is not included in any of our PrEP regimens. And a lot of this, I think, also has to do with the fact that before you put a patient on abacavir, there's additional testing that you have to do for HLA-B5701. So it's not as easy to use as some of our other NRTI options. So our next question is going to be, which antiretroviral medication is associated with decreased effects on kidney and bone health, but may be associated with weight gain or increased LDL cholesterol? And our options here are going to be A, Descovy, or B, Truvada. Awesome. I'm seeing a lot of A's in the chat. So yes, you guys are absolutely correct. Descovy does have a little bit of weight gain and increased LDL cholesterol, but may be a really good option for patients that may be more at risk for having kidney issues. And then our last question is going to be, which antiretroviral medication was only studied for use as PrEP in men who have sex with men, in transgender women, and should not be prescribed for PrEP in our heterosexual women or persons who inject drugs? So our options here again are going to be either Descovy, A, or B, Truvada. All right. So the answer to this one is going to be A. So again, just as a reminder, the reason that Descovy is not FDA approved for the indication for those two populations is because they still haven't been studied. Although I will tell you guys, there are some ongoing trials happening for Descovy in these populations. And so eventually down the line, we may see a new indication. So moving forward, the next question after we've reviewed the evidence is really, how frequently are we actually using our preventative strategies? And so, unfortunately, in the US, the uptake of PrEP has actually been pretty slow. Like I was saying at the beginning of the presentation, if 40% of MSM with a PrEP indication were actually given PrEP, it is predicted that 33% of anticipated infections in the US could be averted completely. And in spite of this impressive estimate, at the time that this was reviewed in 2016, which was 4 years after the FDA approval, only 7% of MSM that had a PrEP indication were actually receiving Truvada. Again, just as a reminder, this was before DISCOTINUING was approved, and the numbers have improved a little bit since then, but we're definitely still missing some populations. And so some potential barriers to uptake that have been seen in the literature is that there is still the stigma. There's difficulty identifying the high-risk patients and a lack of knowledge on both the part of the patient as well as providers on how to utilize the strategy. In addition, access to treatment can also be an issue because these medications are very expensive and patients may have difficulty getting their insurance providers to cover them. Now, that being said, access to treatment should now improve because the federal government released new guidance in July of this year that health insurance companies must offer PrEP to beneficiaries at no cost as part of the Affordable Care Act. Basically meaning that beneficiaries will not be charged copays or deductibles for the medicine, labs, or office visits associated with PrEP. And interestingly, this actually did become part of the requirements in January 2021, but an issue that we're running into is that some insurers have not updated their processes, so still a work in progress. And so how do we go about safely providing PrEP and how do we find our at-risk populations? So one question I want to ask you guys just to see what your thoughts are is this true or false question. Patients presenting for PrEP must be referred to an infectious diseases trained clinician in a specialty clinic for the treatment and follow-up. So would you guys say this is true or false? All right, perfect. I am seeing some B's in the chat. And I agree with you guys 100%. But one thing to keep in mind is that while the answer to this question is false, there is something that's called the PURVIEW paradox that definitely has affected our ability to get uptake of PrEP in the United States. And so what this refers to is it's a contradicting belief that is held by both HIV and ID physicians as well as primary care physicians regarding the optimal clinical setting for delivering PrEP. There have been several surveys that have been published that demonstrate that each group feels the other is responsible for providing PrEP. And this paradox may partially explain why we're seeing decreased uptake of PrEP as a prevention strategy. So, and I think what's really important here is we do have to acknowledge that both sides have valid concerns. From the HIV and ID physician standpoint, they frequently see patients that are already HIV positive, and they don't necessarily encounter the high-risk HIV negative patients who may benefit from PrEP as frequently as a primary care provider would. On the other hand, a lot of times when talking to primary care providers, they express concerns over the frequency of monitoring and the required follow-up, as well as the fact that they are not as familiar with the antiretroviral medications as somebody who is ID trained. But the nice thing about this is that while it can be overwhelming to think about how you would incorporate the amount of monitoring and follow-up that's associated with PrEP, I want to take a minute to point out that there are other members of the healthcare team that could potentially help you out. There are multiple examples in the literature of PrEP clinics that were run primarily by pharmacists or advanced practice providers. And so the article I have referenced here is just one example. And in this one, the pharmacist-led PrEP clinic was basically through a collaborative practice agreement where the pharmacist conducted the initial visits with the potential PrEP candidates, authorized Truvada prescriptions, and conducted follow-up visits and laboratory monitoring every 3 months based on CDC guidelines. And of note, this is actually the current model we're utilizing at the FACS clinic here at University Health, as we are in the process of starting up our own referral service so that we can also see some HIV negative patients that are at high risk for acquisition. Although I will say it's still a work in progress, but if you guys have pharmacists or advanced practice providers in your clinic that could potentially be interested in doing something like PrEP, that's a great resource to utilize. So one thing that's important to know is how do we actually find these high-risk patients? And so really the thing about this is it all starts with an open conversation about sex. The U.S. Public Health Service recommends taking a sexual history for all adult and adolescent patients as part of ongoing primary care. Some common reasons that a sexual history may get deferred include provider discomfort as well as anticipated patient discomfort. And then obviously there's always those situations where you have patients that are presenting with more urgent care needs. But that being said, routine sexual histories are critical in identifying the specific sexual behaviors that increase or decrease a patient's HIV acquisition risk. And providers also really need to avoid limiting sexual history assessments to only select populations. Ideally, a sexual history would be performed at a patient's initial visit, and then because situations and practices change all the time, at least annually moving forward. This can be completed during or prior to the patient's actual visit as well. One thing to keep in mind, since we have EPIC at University Health, is that a lot of times there are these pre-surveys that can be sent out to patients, and potentially this is one thing that you could incorporate in there so that you could review their answers prior to even talking about them and really target the kind of things that you need to talk to them about. I think it's important to let the patient know that you ask these questions of all your patients every year as a part of routine care. And for some people, it may work them it's a judgment-free zone and that everything that they tell you is going to be confidential. What you may run into is that if you have patients that haven't been asked these questions before, some of them may want to know why you're asking them now. And so I put some examples here on the slide of potential ways that you can respond to this question, but really it's important to explain to the patient that their sexual health is important for their overall emotional and physical health. And in addition to that, sexually transmitted diseases may not always actually come with symptoms, and so they can still be detrimental to the patient's health if they're left untreated. When you're taking a sexual history, it is critical to create that judgment-free zone I mentioned earlier. So kind of think of these three things. You want to be straightforward, sensitive, and open to different behaviors. Avoid asking questions in a way that implies there's a right or wrong answer. And then also on our part, we want to avoid our own biases. Don't make any assumptions based on their appearance, age, relationship status, sexual orientation, gender, or gender identity. So there are kind of three questions that you can use as your basic screening questions, and this will help you determine if a patient needs a more detailed risk assessment. So ask them whether or not they've been sexually active in the past year, and if they have had sex with men, women, or both. If they have sex with both men and women, you want to make sure you ask question number 3 regarding how many partners they've had in the past year twice, once for the male partners and once for the female partners. In general, if you have a patient that has multiple sex partners or men who have sex with men, they both need to be asked additional questions to assess their risk for HIV and other sexually transmitted diseases. And if a patient reports that they only have one partner, ask whether this is a casual or long-term partner, and if the patient knows whether or not this partner is having sex with other people. Questions about the use of protection, history of STDs, other risk factors may also be needed for these patients, and a lot of times you'll be able to tell this just by having the conversation. But if you do have a new patient that reports no sexual activity in the previous year, you can also ask them about the gender of their past partners or how many past partners they've had. One thing that might be helpful to think about, categorizing all the different things to potentially talk to the patient about is using the 5 Ps. And so the 5 Ps stands for partners, practices, past STI history, pregnancy, and protection. Again, like we were talking about regarding the patient's partners, you want to identify the gender and number of partners your patient has, as well as finding out whether or not their partner has other sexual partners. For practices, you want to identify the type of sex the patient is participating in, because this will affect what type of screening they need, as well as if the patient or their partners are using alcohol or drugs while having sex. In addition, it's also important to ask about the patient's STI history and whether or not they've previously been tested for HIV in the past, and whether or not they desire to have children. And then finally, you also want to see what are they currently doing to protect themselves from STIs. You may want to try asking the question, what percentage of the time do you use condoms? If that number ends up being less than 100%, at that point, you can ask some additional questions to try to tease out exactly what situations they are more or less likely to use the condoms in. And I know this slide is super busy, so I apologize, but I did also want to cover what specifically the CDC guidelines recommend for PrEP indications. So according to the CDC, men who have sex with men who are not in a monogamous relationship with an HIV negative partner and who have had unprotected anal sex or been diagnosed with a bacterial STI in the previous 6 months should be offered PrEP. Heterosexual men and women that are not in a monogamous relationship and who have a history of infrequent condom use with one or more partners of unknown HIV status, or are in a relationship with an HIV positive partner, or even have been diagnosed with a bacterial STI in the previous 6 months should also be offered PrEP. And then for our final group, any illicit injection drug use with a history of shared injection or drug preparation equipment in the previous 6 months is also an indication. So now that we have our high-risk patients, let's move into talking about your initial PrEP visit. So in your initial PrEP visit, some key information you want to obtain includes any history of or risk for bone or renal health issues, as again, this may sway you either against giving them PrEP altogether, or it may make you pick one agent over the other. In addition, you want to make sure you get a complete list of the patient's current prescription medications and any over-the-counter medications or supplements that they may be using as well, because this is going to be the safety screen for making sure they are on a medication that's going to be safe to be taken with PrEP. Drug allergies, again, is always important. And then finally, another key component of this initial visit is actually documenting the assessment of the patient's risk for HIV acquisition. And that's going to include the sexual risk factors we talked about, as well as any history of injection drug use. So the guidelines do actually include this MSM risk score. You guys can find it in there if you end up wanting to use it later down the line. But basically what you do with this is that if a patient scores 10 or higher using this MSM risk score, they should be offered PrEP. I do want to note though, just because you have a patient that scores a less than 10, that doesn't necessarily mean they can't be provided PrEP. But that might be a person that you need to have a more in-depth risk-benefit discussion prior to actually doing the prescription. Similarly, there's also this persons who inject drugs risk index that helps identify patients who use drugs who should be offered PrEP. And the recommendation on this one is if you have a patient that scores a 46 or greater, that's the person that's going to benefit. The PrEP guidelines do recommend that you're asking all of your patients a routine question like, have you ever injected drugs that were not prescribed for you by a physician? And if they answer yes, that should be followed up with a question, when was the last time that you injected drugs? Basically, if they've done this in the previous 6 months, that's the appropriate time to complete this risk index I have on the slide for you guys. In addition to doing some basic kind of chart diving, look at the patient's labs, you also want to make sure that you rule out acute HIV infection. This is super critical because prescribing PrEP to an HIV positive patient will not treat an active HIV infection, and this does increase the likelihood of them having resistance development down the road. And so I put some signs and symptoms to kind of look out for here for you guys. So that includes things like fever, fatigue, myalgia, skin rash. And a lot of times the onset has been described as flu-like in nature. So for ruling out active HIV, this is also taken from the guidelines, but basically it's just a little algorithm that helps you to think about how you determine the patient's HIV status. Patients are going to be initially eligible for PrEP if their HIV immunoassay is negative and they have not had any signs and symptoms of acute HIV infection in the previous 4 weeks. If you do come across a patient that has an indeterminate initial assay or they have presence of acute HIV symptoms that they're telling you about, the decision to actually initiate PrEP should be deferred and there should be additional testing before you do anything further. And they kind of break this down in the guidelines if you guys need it for reference. In addition, for other required baseline labs, you do need to check the patient's serum creatinine as well as estimated creatinine clearance. Look at hepatitis B and C serologies and then test them for other sexually transmitted infections like syphilis, chlamydia, and gonorrhea. Of note, when we're thinking about the hepatitis B immunity, if they do not have it based on their serologies, they need to be offered hepatitis B vaccination. But it's also really crucial that you know before you give the patient this prescription whether or not they have hepatitis B, because both Truvada and Descovy, because they have tenofovir and emtricitabine in them, they are active against hepatitis B virus as well. So if you take a hepatitis B positive patient, you put them on PrEP, and then a couple months down the line, they actually stop taking it, they're at risk for having a flare in their hepatitis B infection, which can be deadly and put them in the hospital. And then finally, I know I don't have it listed on this slide, but in women of childbearing age, you also want to make sure you obtain a negative pregnancy test before starting PrEP. Then finally, one really, really important part of the initial PrEP assessment is counseling the patients that adherence is going to be really critical. If you guys remember when we were talking about the data, adherence to PrEP is what makes it most effective. And so it's important to have a conversation with the patient about basically their plans for how they're going to take it. Have them plan in advance. What time of day are you planning on taking this medication? And how are you actually going to remember to take that? This is a good time that you can suggest things like pill boxes, phone alarms. Maybe there's somebody in their life that they're not afraid to tell that they're going to be on PrEP that can help them to remember. But a lot of times when we're thinking about these patients, these are going to be young patients that a lot of times aren't on other chronic medications. So remembering to take a pill every day can be hard for them, especially in the beginning. And then for the prescription, there's some important things to discuss with the patients. And really it's that PrEP can only be prescribed to a patient for a maximum of 90 days without refills. The patient needs to know this up front and know that they have to come every 3 months to get those labs done. And the purpose of this is really that we're trying to ensure that they do not have a new active HIV infection. And that's why it's recommended to do this frequent monitoring. Because again, if they were HIV positive, we are putting them at risk of resistance by treating them with a suboptimal regimen that's not actually going to suppress their virus. In terms of counseling points as well regarding the prescription, make sure the patient knows that it's going to take a minimum of 7 days to achieve necessary concentrations for protection. And of note, you'll see that's only for rectal tissue. If you have a female patient, it's going to take at least 20 days in the cervicovaginal tissue. And then for persons who inject drugs, 20 days in blood. Usually I kind of just tell them, 3 weeks, because it's a little bit easier sometimes for people to remember that. In addition, don't forget again, make sure you talk to them about that potential startup syndrome. So, if they do have some headache, nausea, dizziness, give them some ideas of things they can do at home to help with those things that are over-the-counter options, and then remind them that if they can power through this, usually it's going to resolve within the first month. And then again, I cannot stress enough the importance of adherence, because if they don't take the medication, it's not going to work. So for that, you've done your initial visit. Now what happens 3 months later when your patient shows back up? So for 3-month follow-up, the patients are required again to rule out an acute HIV infection. So they need a negative HIV test every 90 days before you prescribe them more medication. And again, every single time, this is 90 days, no refills. This is also a good opportunity to talk to them about if they're having problems with side effects, how their adherence is, and any other ongoing risk behaviors for HIV acquisition that potentially they could be reducing. And at this point, you can also do some testing for STIs, either if you have a patient that you would consider very high risk based on their behaviors, or if they're actually reporting symptoms that are consistent with an STI. In addition to those 3-month requirements, it's also recommended that you monitor serum creatinine at least every 6 months, although there may be some patients, just depending on what else they have going on comorbidity-wise, that may need more frequent monitoring than that, and you can do this at 3 months. Of note though, I just want to say a rise in serum creatinine is not a reason to withhold PrEP, as long as their creatinine clearance is still greater than 60 if we're talking about Truvada, or if you have a patient that's on Descovy, 30 is fine. And then even if you have a patient who is asymptomatic for STIs or isn't super high risk for acquisition, you still want to make sure you're testing them at least every 6 months for syphilis, chlamydia, and gonorrhea. And then finally, regarding follow-up, PrEP isn't intended to be taken forever, because sometimes the patient's risk factors or wishes to continue PrEP are going to change over time. And so at least annually, you want to make sure you're evaluating them for, is this still the right choice for you? There's a large number of reasons that patients may not want to be on PrEP anymore. It's personal choice. Maybe their life situation has changed that has resulted in them having a lower risk of HIV acquisition. Maybe they're experiencing intolerable toxicities and they just really don't like the medication. In terms of things from our side, if you have a patient with chronic non-adherence, despite making some interventions to potentially improve their daily pill taking, maybe that's not the right person for PrEP. And then finally, we do have to think about the worst case scenario. There are some patients that may potentially acquire HIV. And so how do we actually discontinue PrEP safely? Protection from the HIV infection is going to wane over a 7 to 10 day period after they stop using their daily PrEP if they were actually pretty adherent to it. And so it's important to know that some patients have acquired HIV infections soon after they stopped the PrEP. And so they need to be counseled about alternative prevention methods like condoms, but also this is a good time to have a conversation about when do we use post-exposure prophylaxis? How soon do you need to come in? Where would you go to receive this? All things that they may run into just so they have that knowledge for themselves. In addition, you also want to make sure you document in their medical record the HIV status at the time of discontinuation, their reason for discontinuing, and then if there's any issues with med adherence, that's a good thing to put into the chart just in case they come back later. And then finally, if you have a patient that goes off for a couple months and then decides they want to come back and resume PrEP, they still need to undergo all those same pre-prescription evaluations as a person who was originally newly prescribed PrEP, including again that HIV test because you want to establish that they are still without HIV infection. In addition, if you have somebody coming back, that's a good time to have a frank discussion that clarifies like what changed, why do you want to be on PrEP again? Again, so you can have an open, honest conversation with your patients about what's going on. So I appreciate y'all's attention today. I want to summarize briefly for you some of the things we talked about. So like I said, the overall number of new HIV diagnoses has been decreasing in the US, but there are still certain groups that continue to be disproportionately affected, really highlighting our MSM population. We talked about Truvada and Descovy, which are both FDA approved currently for PrEP. And we also talked about how do we actually identify these patients. And it's really critical to take a thorough sexual and behavioral history on patients because that's how you're going to figure out that they might be a good candidate. And then finally, for your eligible patients that are initiated on PrEP, this is going to require every 3-month follow-up to rule out acute HIV infection. And again, great opportunity to provide that ongoing risk reduction counseling. So I have lots of references in here for you guys, but at this point, I'd like to open it up for any questions that you guys may have for me.
Anybody
Dr.
with questions?
Kirkpatrick,
Yes.
quick question. You had mentioned that every 3 months for the monitoring
Yep.
labs. At what point, you mentioned the creatinine clearance part, what about the others like the cholesterol and LFTs? What are the numbers or fold increases would you be like, say we should stop the medication or do we add additional medication for cholesterol? So those are my questions. Thank you.
For sure. That's a really good question. I will tell you the guidelines don't necessarily recommend that you are routinely monitoring like LFTs or cholesterol with these medications. And I think part of that is even when we're talking about like from experience with HIV positive patients, the LDL increase is not necessarily predictable for Descovy. And so it's difficult to say like, oh, if you see this much of an increase, that's definitely the Descovy, you need to stop it. I think it's going to have to be a decision you make on an individual basis, case by case. And again, if you have somebody who has high cholesterol at baseline, maybe that's a person where you need to be a little bit more cautious, check it just to see when you start Descovy, like how far did it go up? But there's not necessarily specific guidance, like if it's too high, just stop the Descovy completely. Because again, it's going to be very patient specific what that response is going to look like. I honestly have not had a lot of people that had any issues with LFTs related to either of those medications. And so it's not necessarily something I think about specifically for Truvada and Descovy. But if you're seeing elevations in LFTs, that's time to explore, you know, what are the causes of this? What other things might be going on regarding comorbidities? But again, highlighting, if you have somebody with hepatitis B specifically, they need to know that they cannot stop that medication once they start it because it will lead to a Hep B flare.
Thank you.
Yeah, of course.
Any other questions?
I will give a quick plug. You guys may remember at one point I mentioned that we are working on doing a PrEP clinic in fax. I'm one of the people that's going to be seeing the patients for that. So I know if you guys are really busy and PrEP doesn't fit well into your workflow, potentially, especially if it's somebody with insurance, because those are the patients that we can currently see. If you want to give them a referral over to us, we're happy to help out with that.
Okay, I see some comments there in the chat box, just thanking you very much, Dr. Kirkpatrick. So with that, I will go ahead. If anybody has any questions, just let us know. Also, if you could take a moment to complete the survey, it's linked there in the chat box. But thank you so much, Dr. Kirkpatrick, for your presentation today. And thank you everybody for joining us.
Yes, thank you for having me. Have a great day, everyone.